Welcome to the Deep Dive. Today we are plunging into a really critical area of patient care, the vascular access for hemodialysis. For millions of patients worldwide, this access is literally their lifeline, isn't it? The essential connection allowing them to get the blood purification they need to survive.
Absolutely. And as you know, creating and maintaining a functional access point is, well, it's a constant challenge. It's fraught with complexity, potential pitfalls.
Yeah, the stakes are incredibly high. When a patient's access fails, it's not just an interruption to therapy.
No, it can lead to repeated hospitalizations, serious infections, and it significantly impacts their quality of life and even survival. So having clear evidence-based guidance is, well, it's paramount for navigating this complex landscape.
And that's exactly what we're diving into today. Our source material is a key document in this field. The 2018 Clinical Practice Guidelines for Vascular Access from the European Society for Vascular Surgery, and importantly, it's endorsed by the Vascular Access Society.
Right, that adds significant weight. And this isn't just a dry textbook. It's a synthesis of knowledge from a truly multidisciplinary group of experts. It brings together perspectives from surgery, nephrology, radiology, and importantly, nursing.
So it's designed to be a practical guide for specialist clinicians like you listening.
Exactly. Summarizing the evidence up to 2017, offering recommendations to inform your daily decisions, whether that's at the bedside in the clinic or, in the operating room.
So our mission for this deep dive is simple. Take these comprehensive guidelines, really extract the most important nuggets, understand the strength of the evidence behind those recommendations, and highlight the clinical pearls that are truly actionable for your practice.
We want to offer you a structured exploration, maybe a shortcut, to understanding the core insights without having to pore over every single detail yourself.
Okay, so where do we start?
Well, we'll begin by looking at the framework, how these guidelines were put together, the methodology, and the key language, the definitions they use. Then we'll set the stage with the big picture, the changing landscape of ESRD epidemiology and patient demographics.
Right, the context.
And then, from there, we get into the heart of it, the detailed considerations for actually creating vascular access, covering everything from patient assessment, vessel suitability, imaging, right through to surgical approaches and those early complications.
Okay, creation covered. What follows?
Then we'll discuss the crucial ongoing care. Surveillance, monitoring, those all-important cannulation techniques, and the vital role of the nursing team in all of this.
And finally, we tackle the challenges you face day to day, right? The late complications.
Exactly. Things like stenosis, thrombosis, infection, aneurysms, central venous obstruction, limestemia, plus the really difficult world of complex and tertiary access for those patients with very limited options.
And we'll also touch on what the guidelines say about where we still need more evidence, the gaps.
Right. Our hope is that this deep dive gives you a clearer understanding of these guidelines, empowering you to make informed decisions based on the best available evidence and ultimately help improve outcomes for your patients.
Okay, sounds like a plan. Let's get started by understanding the foundation of this document, the methodology.
Right. So the core purpose of these guidelines was really to synthesize the current clinical practice for all the different specialists involved in hemodialysis and vascular access care. That's surgeons, nephrologists, radiologists, nurses, everyone.
So a unified approach.
Exactly. They wanted to create a comprehensive guide, starting from that initial patient assessment and planning, going right through the creation process and into the long-term management of complications.
And they're pretty clear that this is intended as a guide, not some kind of rigid rule book.
Yes, absolutely. They explicitly state that, allowing for flexibility based on the unique circumstances of individual patients. Which is essential, isn't it? When you're dealing with a population as complex and varied as those with end-stage renal disease.
Yeah, you can have a one-size-fits-all approach.
No. They recognize that not every decision is backed by a perfect, multi-center, randomized, controlled trial.
So who are the experts involved in actually putting this together?
The Vascular Access Writing Committee was intentionally multidisciplinary. It included members from both the European Society for Vascular Surgery and the Vascular Access Society, drawing from various European countries and, importantly, different types of clinical settings.
So surgeons, nephrologists,
radiologists, and clinical nurses.
Yes.
This mix was vital to ensure the recommendations were genuinely applicable and practical across that entire spectrum of care, not just, siloed within one specialty's viewpoint.
That integrated approach feels really key in a field like this.
Yeah.
What was their process for actually gathering the evidence? How rigorous was it?
It was pretty systematic. They conducted literature searches across the major databases, Medline, Embase, the Cochrane Library. They did this for each topic area covered in the guidelines.
And they had specific criteria.
Yes, they included peer-reviewed published literature up to August 31st, 2017, and they specifically excluded things like published abstracts or conference proceedings, really focusing on the more established evidence base.
Did they prioritize certain types of studies, like randomized trials?
They did. Priority was given to randomized clinical trials, meta-analyses, and systematic reviews, the highest levels of evidence. But importantly, they also included non-randomized controlled trials, non-controlled trials, and well-conducted observational studies, like cohort and case control studies.
Which makes sense, because sometimes that's all you have for certain clinical questions.
Exactly. It acknowledges that for many practical questions, that top-tier level A evidence simply doesn't exist yet, so they had to rely on the best available data.
Okay, so they gather the data. How did they evaluate the quality of that evidence then?
They use the GRADE approach, grading of recommendations, assessment, development, and evaluation for assessing the quality of evidence for each outcome. And then, to translate that evidence into clinical recommendations, they use the grading system from the European Society of Cardiology.
Right, the ESC system.
Yeah.
Let's make sure we're crystal clear on that grading system because it underpins everything. What do the different classes mean for the clinician reading this?
Yeah, this is absolutely critical for interpreting the recommendations correctly. So a Class 1 recommendation means there's clear evidence or broad consensus that a given treatment or procedure is beneficial, useful, and effective. It's a strong recommendation. Basically, you should do this.
Okay, Class 1, do it.
Right. Then you have Class 2. This means the evidence is less definitive or there might be some conflicting opinions.
And there are two types of Class 2.
Yes. Class 2 means the weight of evidence or opinion is in favor of usefulness or efficacy. So the recommendation is that it should be considered.
Should be considered.
Okay. Then Class 2B means the usefulness or efficacy is less well established by evidence or opinion. So the recommendation here is that it may be considered. It's a weaker suggestion.
May be considered. Got it. And Class 3?
Class 3 means there's evidence and a general agreement that a treatment or procedure is not beneficial, useful, or effective. And in some cases, it might even be harmful. This is a strong recommendation against doing something.
Okay, so Class 3, don't do it, potentially harmful. And the level of evidence, A, B, C.
Right, that tells you about the quality of the evidence supporting that recommendation class. Level A means high-quality evidence, usually from multiple randomized trials or meta-analyses. Strong data.
Top tier.
Exactly. Level B means moderate evidence, perhaps from a single good randomized trial or large, well-done, non-randomized studies.
Still pretty solid.
Generally, yes. And level C means the recommendation is based primarily on expert opinion, maybe case series or very small studies. The evidence base is weaker.
So understanding that Class 1 is strong for, Class 3 is strong against, and Class 2 AB are these shades of consider, combined with the level of evidence, A, B, or C, really tells you how much confidence to place in that specific recommendation.
Precisely. And the guidelines are clear. Even when extensive level A evidence wasn't available, they still made recommendations based on the best evidence they had at hand, often level B or C. If there were conflicting views among the committee members, they had a formal consensus process to hash it out and arrive at a unified recommendation.
And they plan to update this?
Yes, they mentioned plan for periodic updates, potentially every 3 years, which is important in a field that evolves.
They also noted that conflicts of interest were collected and reported. That transparency is pretty standard practice now, isn't it?
It is, and it's crucial. Understanding this whole methodology, the systematic review, the grade assessment, the ESC classification, is really fundamental for you as a clinician using this document.
Why is it so important?
Because it allows you to critically appraise each recommendation. You can understand the basis for it. Not every piece of advice carries the same weight, and knowing the class and the level helps you apply it appropriately, thoughtfully, to your individual patient situation. It's not just a list of rules, it's graded guidance.
That makes sense.
Yeah.
So before we dive into the epidemiology and the specific recommendations, let's quickly nail down some of the key terms used throughout these guidelines. We won't go through every single one, obviously, but the ones that are most crucial for understanding this deep dive.
Agreed. Clear terminology is absolutely vital, not just for interpreting research, but for communication among the whole multidisciplinary team, surgeons, nephrologists, nurses, radiologists. Misunderstandings can lead to errors.
So the core definition first.
Right. Vascular access itself is defined as a surgically created or percutaneously inserted connection to the blood circulation, specifically designed to achieve those very high blood flow rates needed for efficient hemodialysis.
And the main types we'll be discussing.
The main surgical types are an arteriovenous fistula, that's an AVF, which is an autogenous anastomosis, meaning it uses the patient's own artery and vein. Then there's an arteriovenous graft, an AVG, which uses a prosthetic graft material to connect an artery and a vein.
And the catheters.
The two main central venous catheters are the non-tunneled central venous catheter, an NTCVC, which is typically an uncuffed temporary line used for acute situations or bridging, and the tunneled cuffed central venous catheter, a TCCVC, which is a more permanent type, tunneled under the skin with a cuff to help prevent infection and secure it, intended for longer-term use when an AVF or AVG isn't possible or hasn't matured.
Okay, those are the basic types. Now, the outcome measures, specifically those patency definitions, they can be a bit tricky sometimes.
They really can be, and they're crucial for interpreting study results. So let's clarify.
This is the time interval from the creation of the access until the very first intervention is needed because of dysfunction or thrombosis, or until the access is abandoned. Think of it as intervention-free survival.
Okay, no interventions needed yet.
Right. Then there's assisted primary patency. This is the interval from creation until the first occlusion, the first thrombosis occurs. But crucially, this period includes any interventions that were done before that thrombosis to maintain patency. So it's thrombosis-free survival, but potentially with some help along the way.
Got it. Interventions allowed, but no clot yet. And secondary patency.
Secondary patency is the total lifespan of the access. It's the interval from creation until the access is finally abandoned, and this period includes one or more interventions performed after a thrombosis or dysfunction occurred to salvage or maintain its function. It's the overall functional duration achieved with interventions.
That's a much clearer breakdown. And what about the difference between maturation and functionality? They sound similar.
They do, but the distinction is important. Maturation is a pre-cannulation concept. It refers to those physical changes that happen after an AVF is created, the increase in blood flow, the increase in vein diameter, the thickening of the vein wall, or after an AVG is placed tissue incorporation. These changes make the access suitable for cannulation with 2 needles. So a mature vascular access is one that's expected to be ready for effective 2-needle dialysis.
So maturation is about readiness.
Exactly. Whereas functionality is a post-cannulation concept. A functional vascular access is one that has actually been successfully used, typically defined as being cannulated with 2 needles for at least, say, 6 hemodialysis sessions over 30 days, delivering the prescribed blood flow and achieving adequate dialysis. So maturation is the potential, functionality is the proven performance.
Okay, those definitions are definitely key bedrock for understanding everything that follows. Thanks for clarifying.
No problem. Having that common language is really foundational before we get into the clinical details.
All right, let's step back now and look at the big picture again, the patient population that actually needs this specialized care. What do the guidelines tell us about the epidemiology and the demographics of end-stage renal disease? This sets the context for everything else.
Absolutely. And it's important context for understanding the challenges. So end-stage renal disease, or chronic kidney disease stage 5, is defined as the stage where the kidneys can no longer support life without some form of replacement therapy, dialysis, or transplantation. The guidelines make a key point right at the start. Incidence figures based on patients starting RRT actually underestimate the true incidence of ESRD.
Why is that?
Because they don't capture patients who might have reached end-stage kidney failure but, for various reasons, aren't actually treated with RRT. So the true burden is likely higher than the RRT initiation stats suggest.
Okay. And what were the trends they observed in patients starting RRT leading up to 2017?
They noted an almost exponential rise in the number of patients starting RRT annually over the preceding decades. The guidelines point to several potential drivers for this increase.
Such as?
Well, one major factor is patient selection. They suggest that older patients, and those with more comorbidities, who perhaps wouldn't have been offered dialysis decades ago, are now routinely accessing therapy. So the threshold for starting treatment has changed.
That makes sense. What else?
Another factor is competitive risks. The idea here is that because fewer people are dying prematurely from other major causes like cardiovascular disease or cancer, more individuals are surviving long enough to actually develop end-stage renal disease.
So success in other medical areas is leading to more patients reaching ESRD.
Potentially, yes. And then, importantly, there's the possibility of a true increase in the incidence of chronic kidney disease itself. This is strongly linked to the rising global prevalence of the main underlying drivers, especially type 2 diabetes and hypertension.
They cite the Framingham study, don't they?
Yes, as a stark example. It showed a doubling of type 2 diabetes incidence between the 1970s and 1990s. They also mention potential contributions from increased use of nephrotoxic drugs like NSAIDs, certain antibiotics, and chemotherapy.
So it's a combination of factors: more people living longer, potentially more underlying kidney disease drivers, and broader access to treatment. What does that mean for the overall prevalence, the total number of people living with ESRD?
Prevalence data mostly comes from RRT registries. They use U.S. data from 2008 as an illustration. Over 500,000 prevalent ESRD patients at that time. About 70% were on dialysis, 30% had a transplant.
And the main causes, still diabetes and hypertension.
Overwhelmingly. Diabetes accounted for 44% and hypertension for nearly 28% of cases in that U.S. data. Rising prevalence happens because of either increasing incidence, more new cases, or increased survival of patients already with ESRD. The guidelines suggest that as incidence rates seem to be flattening somewhat more recently, the continued growth in the prevalent population is likely explained by people living longer on dialysis or with a transplant.
This really hammers home the need for upstream public health efforts focused on preventing and managing diabetes and hypertension, doesn't it?
It absolutely does. It's a crucial public health message embedded right within these clinical vascular access guidelines. Now, looking at the demographics, the picture isn't uniform globally. It's influenced by genetics, lifestyle factors, and crucially, access to care.
How so?
Well, incidence rates are notably higher in certain populations. For example, African Americans and Native Americans in the U.S., or Aboriginal populations in Australia and New Zealand. This is often linked to higher rates of diabetes and hypertension in these groups. Conversely, in many developing countries, lower reported rates likely reflect limited availability and access to RRT rather than genuinely lower rates of kidney disease itself.
And we can't ignore the impact of the aging population, can we?
Yeah, that's a huge factor globally.
Hmm.
The elderly, typically defined as over 65, make up a substantial and rapidly growing fraction of the RRT population, somewhere between 25% and 30% in most registries.
They mention a dramatic increase in the U.S.
Yes, the proportion of patients over 65 starting dialysis increased significantly year on year. This older demographic often comes with a higher burden of comorbidities. Things like obesity, type 2 diabetes, and peripheral vascular disease are much more common.
And how do these patient characteristics, older age, more comorbidities, directly impact the challenges of vascular access?
It makes a huge difference. These comorbidities, particularly diabetes and PVD, make successful creation and maturation of a native arteriovenous fistula much more difficult. The vessels are often smaller or more diseased. And these same factors, older age, diabetes, PVD, obesity, are independent predictors of central venous catheter use. So this demographic shift is a major contributor to the vascular access challenges clinicians face every day.
So how has vascular access practice changed or tried to adapt in response to this evolving patient population?
Well, there have been major initiatives. For instance, the Fistula First initiative in the USA led to a really significant increase in AVF use among prevalent hemodialysis patients, those already on dialysis. It went from about 34% in 2003 to over 60% by 2012. That's a big shift in practice for established patients.
That's a success story for prevalent patients. But what about patients who are just starting dialysis? What does their access look like at initiation?
This is where the picture is much more concerning, and it's a critical point in the guidelines. U.S. data from around 2009 to 2014 showed that at the start of dialysis, only about 14% of patients had a usable AVF. Another 3% had a usable AVG.
Only 17% combined, starting with a permanent access. What about the rest?
The vast majority, over 80%, were starting hemodialysis using a central venous catheter. Another 16% or so had an AVF that was created but still maturing.
80% starting with a catheter. That seems incredibly high, especially given the known risks associated with catheters compared to fistulas or grafts.
It is shockingly high, and it's a persistent problem highlighted internationally. Data from the DOPPS study, Dialysis Outcomes and Practice Pattern Study, also shows wide variations in vascular access practice globally. But the finding is consistent. Patients dialyzing with a catheter have a significantly greater morbidity and mortality risk compared to those with a usable AVF or AVG.
And the lowest risk is with a usable fistula.
Yes, the lowest mortality risk is clearly associated with having a usable AVF.
Are there specific patient factors that are consistently linked to starting dialysis with a catheter instead of an AVF?
Yes, the data consistently shows that patients were less likely to initiate dialysis with an AVF if they were female, older, had a higher body mass index, had diabetes, or had diagnosed peripheral vascular disease. It's often the patients with more complex underlying health issues.
And what about system factors? Does the healthcare system itself play a role, like how quickly patients get referred for access creation?
Absolutely. This makes a huge difference. The DOPPS data revealed significant variations between countries and the time elapsed from referral to the actual creation of the vascular access. Countries with shorter waiting times for surgery and subsequent maturation were much more likely to have patients starting dialysis with a functioning permanent access already in place.
So timely referral and surgery are key. What about patient preference?
Patient preference for access type also varied across countries, according to DOPPS. Preference for CVC was often associated with those same factors, making AVF creation difficult, older age, diabetes, poor vessel quality. So patient preference might reflect perceived difficulty or past negative experiences.
Okay, so this epidemiological and demographic snapshot really paints a clear picture. We have a growing population of older patients with more comorbidities like diabetes and vascular disease. This makes creating successful native fistulas more challenging, which contributes to the persistently high use of central venous catheters when patients first start dialysis, despite the well-documented risks of catheters compared to AVFs.
Exactly. It perfectly frames the clinical challenges and the context for why these guidelines are so necessary. We need strategies to improve timely access creation and maturation, especially for these higher-risk patients.
All right, that's a crucial backdrop. Let's transition now from that big picture context to the practical steps involved in actually creating the vascular access. This seems like where the foundation for long-term success or failure is really laid.
Absolutely. This section gets into the real nuts and bolts. The primary goals, as you'd expect, are safety, efficacy, durability, and cost-effectiveness. And as we've already touched on, the autogenous AVF using the patient's own vessels is generally the preferred starting point whenever possible.
But even before you get to the operating room, the guidelines emphasize a really critical step, something that needs to happen much earlier for patients who are potentially heading towards kidney failure.
Yes, and this is a message that needs to reach all healthcare providers, not just the vascular access specialists or nephrology teams. It's about venous preservation.
Tell us more about that. Why is it so crucial?
In patients who have chronic kidney disease and are likely, or even possibly, going to require hemodialysis in the future, it is absolutely essential to preserve the superficial veins in the forearm and the antecubital fossa, specifically the cephalic vein, the basilic vein, and those veins around the elbow in both arms if possible.
Why those veins in particular?
Because these are the prime candidates, the go-to vessels, for creating a successful autogenous arteriovenous fistula later on. Any damage to these veins from things like repeated 5E cannulae, blood draws, venipuncture, or even PICC lines can cause thrombosis, scarring, or inflammation, thrombophlebitis, rendering them unusable for future access creation.
So damaging these veins early on can severely limit the patient's options for the best type of access later.
Precisely. It can force the use of more proximal fistulas, grafts, or even long-term catheters, all of which have higher complication rates than a good distal AVF. The guideline recommendation on this is explicit and quite strong. Recommendation 13. In patients undergoing or likely to require hemodialysis, intravenous cannulae and venipuncture of the cephalic, basilic, and the antecubital veins may be harmful and should not be performed. This is a Class 3 recommendation with a Level C evidence grade.
Okay, let's unpack that. Class 3 means do not do this, potentially harmful. And Level C means it's based on expert opinion and clinical experience rather than strong trial data. But the Class 3 designation gives it real weight.
Exactly. Even without large trials, the consensus among experts is that the potential harm of losing these critical veins for future access is so significant that this practice should be avoided. It's based on sound physiological principles and extensive clinical experience.
So what should be done if someone with CKD absolutely needs an IV or a blood draw?
The recommendation is to try and use veins on the dorsum, back of the hand, whenever possible. This preserves those larger, more crucial forearm and elbow veins. Getting this message out to primary care, hospital wards, emergency departments requires real multidisciplinary communication and education.
That's a really important practical point. Okay, moving closer to the actual surgery, what about preparing the patient or the limb just before the procedure? Any specific recommendations?
The guidelines touch on a few things. Preoperative arm exercises like squeezing a ball have been studied. They show some improvement in arterial and venous diameters and resting blood flow. So it's considered likely beneficial for helping with subsequent maturation, although the guidelines note it's not definitively proven by strong trials to improve ultimate patency outcomes compared to, say, just doing exercises after surgery.
Interesting. What about hydration status?
This is important. Adequate preoperative hydration should be considered for vascular access creation. That's recommendation 14, a class 2, a recommendation with level B evidence.
Class 2A, level B, so should be considered based on moderate evidence. What's the rationale?
The main reason is that hypotension or low blood pressure during or immediately after the surgery is a known risk factor for early thrombosis of the newly created access. One randomized study specifically showed that preoperative rehydration using plasma expanders actually improved primary AVF patency, especially in patients who had borderline vessel sizes to begin with. So keeping the patient well hydrated seems prudent.
Makes sense. What about giving antibiotics prophylactically before the surgery? Is that routine?
Not necessarily for all access creations. The guidelines state there's little evidence to support routine prophylactic antibiotics before an uncomplicated AVF creation. The infection risk is generally low.
But what about grafts or more complex fistulas?
That's different. For arteriovenous grafts, AVGs, or for complex AVFs, for example, those requiring interposition grafts or vein transpositions, the infection risk is significantly higher. In these cases, broad-spectrum prophylactic antibiotics should be given prior to insertion. That's recommendation 15, a strong Class 1 recommendation based on level B evidence.
Okay, class 1, level B for AVGs and complex AVFs. Any specific antibiotics mentioned?
They suggest a parenteral first-generation cephalosporin as a typical choice. If the patient is a known carrier of multi-resistant organisms like MRSA, then a glycopeptide like vancomycin or teicoplanin should be considered. And for ESBL-producing organisms, potentially a carbapenem based on local sensitivities. The key is giving it about 60 minutes before the incision to ensure adequate tissue levels during the procedure.
Got it. What about antiplatelet agents like aspirin? Should patients be on them before surgery?
The evidence here is a bit mixed, described as incomplete in the guidelines. There have been meta-analyses suggesting antiplatelets might reduce early vascular access thrombosis, but the trials included had variations in the drugs used, the timing of administration, pre-op versus post-op, and whether they looked at AVFs or AVGs.
So not entirely clear-cut.
Not entirely. Some trials giving antiplatelets preoperatively did show benefits, aspirin reducing perioperative fistula thrombosis, clopidogrel reducing primary failure of AVFs, though not affecting maturation significantly. Ticlopidine showed a trend but wasn't statistically significant, and it's largely off-market anyway. So despite the heterogeneity, the guidelines suggest it's advisable to consider giving aspirin or another antiplatelet agent preoperatively and continuing it postoperatively. The formal recommendation is antiplatelet agents should be considered prior to AVF or AVG creation to reduce the risk of early thrombosis. That's recommendation 16, a class 2A level B recommendation.
Okay, should be considered, again, based on moderate, if somewhat mixed, evidence. Now, what about the physical examination right before the procedure? We touched on it, but how important is it?
It's fundamental. Even with good preoperative imaging like ultrasound, the hands-on physical exam just before surgery is crucial. The guidelines state that patients should be examined prior to surgery with a tourniquet applied in a warm room, and the proposed site of the AVF should be marked preoperatively. That's recommendation 17, a class 1 recommendation, level C.
Class 1, level C. So strongly recommended, even if based on expert consensus and best practice rather than trial data. What are you looking for in that exam?
You're assessing the upper limb pulses carefully. You're examining the superficial veins with a tourniquet applied, checking their size, condition, continuity. You're actively looking for any subtle signs of central venous stenosis, like prominent collateral veins on the chest wall or slight limb edema. You're noting the location of any previous CVCs or pacemaker leads. And based on all this, you confirm and mark the chosen optimal site for the anastomosis. It's about final verification and planning.
Makes sense. What about anesthesia choices during the surgery?
Several options exist. Local anesthesia injecting something like lidocaine or bupivacaine around the site is often sufficient for straightforward AVFs or AVGs in the forearm or antecubital fossa.
But are there advantages to other types, like a regional block?
Potentially, yes. Regional anesthesia, like an axillary or brachial plexus block, does take more time and requires an experienced anesthetist. However, it causes significant vasodilation in the arm, which some surgeons find helpful, and it might even allow for the creation of more distal AVFs that wouldn't have been possible otherwise. There's some evidence suggesting it might lead to better patency rates compared to local anesthesia alone.
So what's the recommendation?
Regional anesthesia should be considered in preference to local anesthesia for vascular access surgery because of a possible improvement in access patency rate. That's recommendation 18, a class 2A, level B recommendation.
Okay, another should be considered based on moderate evidence suggesting a potential benefit. Now, a potentially controversial one, systemic heparin during the procedure.
Yes, this is definitely debated. The evidence is conflicting. Some older trials suggested systemic heparin might improve early patency without increasing complications. However, a meta-analysis cited in the guidelines concluded that systemic heparin had no effect on patency rates, but did significantly increase the risk of postoperative hemorrhage and hematoma.
So the meta-analysis argues against it.
Based on that meta-analysis, yes. The guideline recommendation is actually a class 3. In order to decrease the exposure of patients to heparin, the source text is cut off, but implies avoidance. Avoid systemic heparinization. That's recommendation 26, a class 3 recommendation with level B evidence. So, don't do it potentially harmful, based on moderate evidence showing increased bleeding risk without proven patency benefit.
But you mentioned conflicting experience.
Right. The guidelines acknowledge that some surgical units, particularly those that routinely use tourniquets during the surgery, report not seeing this increased bleeding risk with systemic heparin. So there's some discrepancy between the meta-analysis findings and some clinical practices. However, the formal recommendation leans against routine systemic heparin. Local installation of heparinized saline into the clamped vessels or graft is still common practice, though.
Okay, that covers the technical aspects of preparing for and performing the surgery. Now, the big question. How do we actually choose the type of access and the optimal location for a specific patient?
This is really the core of the preoperative decision-making process. It involves integrating patient factors, vessel assessment findings, and following a generally accepted hierarchy of preference.
And that hierarchy starts with?
The general principle is create an autogenous AVF using the patient's own vessels as far distally as possible, typically starting at the wrist in the non-dominant arm, provided the vessels there are suitable.
Okay, suitable vessels, especially for that preferred distal radiocephalic AVF at the wrist. What defines suitable in terms of size?
Preoperative duplex ultrasound is key here. Studies suggest that AVF patency rates are generally poor if the internal diameter of the radial artery and orb of the cephalic vein at the wrist are less than 2.0 millimeters when measured by ultrasound.
So 2 millimeters is a sort of minimum threshold.
It's a guideline. The formal recommendation is, in adults when the inner radial arterial diameter is less than 2.0 millimeters, and order of the cephalic venous diameter is less than 2.0 millimeter by ultrasound measurement, an alternative site for access should be considered. That's recommendation 19, a class 2A, level B recommendation. Below that threshold, the chances of maturation and long-term success are significantly lower.
And the preference for the non-dominant arm, is that a strong recommendation?
It's recommended practice when possible. The guideline states, when vessel suitability is adequate, the non-dominant extremity should be considered as the preferred location for vascular access. That's recommendation 5. A class 2 recommendation, but level C evidence. So it's strongly advised based on practical considerations and expert opinion rather than hard trial data comparing outcomes. It just makes daily life easier for the patient if their dominant hand isn't involved with the access.
Makes practical sense. Now, what if the patient has had central lines before or has a pacemaker or defibrillator leads in place? Does that affect the choice of arm?
Absolutely, and this is a critical point. If there's an indwelling central venous catheter or pacemaker defibrillator leads, the vascular access should be created in the opposite arm. That's recommendation 20, a very important class 1 recommendation, level C evidence.
Class 1, level C again. Strongly recommended based on expert consensus because of the risk.
Exactly. The risk of underlying central venous stenosis or even occlusion on the side where a catheter or lead has been present is very high. Trying to create an access on that same side is often doomed to fail because the outflow pathway back to the heart is compromised. You must go to the contralateral arm if at all possible.
Okay, so we start distally at the wrist, radiocephalic AVF. If the vessels aren't suitable there, 2 millimeters, or if a wrist fistula fails, where do you typically go next?
You generally move more proximally up the arm. You might consider other forearm AVFs if suitable vessels exist there. If not, the next common site is usually the antecubital fossa, the elbow crease, creating either a brachiocephalic AVF, BCAVF, connecting the brachial artery to the cephalic vein, or perhaps a brachiobasilic AVF, BBAVF, connecting the brachial artery to the basilic vein.
Are there situations where you'd choose one over the other in the upper arm or perhaps skip the cephalic vein?
Well, if the upper arm cephalic vein is thrombosed, scarred, or just not suitable, but the basilic vein is good, then a basilic vein transposition, BVT, become a very important option. This involves surgically mobilizing the deeper basilic vein and bringing it more superficially to make it usable for cannulation. The guidelines strongly favor this over using a graft in this situation. When the upper arm cephalic vein is unavailable, a basilic vein transposition arteriovenous fistula should be considered in preference to an arteriovenous graft. That's recommendation 21, a class 2 a recommendation, but based on high-quality level A evidence.
Level A evidence supporting BVT over a graft. That's significant. Why the preference?
Because multiple studies and meta-analyses have shown that BVTs, while technically more complex than placing a simple graft, generally have better long-term patency rates and, importantly, a significantly lower risk of infection compared to prosthetic grafts in the upper arm.
Okay, so the hierarchy is generally distal AVF, then proximal AVF, like BC-AVF or BBA, via BVT. What if all suitable autogenous vein options in both arms have been exhausted?
Then, unfortunately, you have to move to using prosthetic arteriovenous grafts, AVGs, in the upper limb. These can be configured as forearm loops or straight grafts or brachioaxillary grafts in the upper arm. Grafts significantly expand the possibilities when native veins aren't an option.
And if even upper extremity options, including grafts, are impossible or have failed?
That's when you have to reluctantly consider the lower extremity. A lower extremity vascular access should be considered only when upper extremity access is impossible. That's recommendation 6, a class 2A, level C recommendation. It emphasizes that this is really a last resort.
Why the reluctance? What are the downsides of lower limb access?
The risks are significantly higher compared to upper limb access. There's a greater risk of vascular access-induced limb ischemia, VGILI, a much higher risk of infection, especially with grafts in the groin area, and it can be less comfortable and more limiting for the patient.
If you do have to go to the lower limb, is there a preferred option there, similar to the BVT preference in the arm?
Yes, there is. When lower limb vascular access is necessary, a femoral vein transposition, FVT, should be considered in preference to an arteriovenous graft, typically placed in the thigh. That's recommendation 22, a class 2A, level B recommendation.
So similar logic. Better patency and lower infection risk for the transposed native vein compared to a graft.
Exactly. Studies have shown better patency and much lower infection rates with FVTs compared to thigh grafts. However, FVTs do carry a higher risk of causing limb ischemia, so very careful patient selection, avoiding those with significant PAD, and surgical technique, like tapering the vein, are crucial to mitigate that risk.
Okay, switching back to grafts for a moment. Are there specific situations where one type of graft material might be preferred over another? You mentioned infection earlier.
Yes. If an AVG absolutely must be created in the presence of existing infection or in a contaminated field, a biological graft, like processed bovine or ovine tissue, should be considered in preference to a standard synthetic graft, like EPTFE. That's recommendation 23, class 2A, level C. This is based on the expert opinion that biological grafts might be more resistant to infection than synthetic materials.
And what about those newer grafts designed for early cannulation?
Right. For patients who have difficult central venous access, making temporary catheters risky or impossible, and who require hemodialysis urgently, the implantation of a self-sealing arteriovenous graft is recommended.
Sure.
That's recommendation 24, a strong class 1 recommendation, level B evidence. These grafts, like certain polyurethane or multi-layer EPTFE types, are designed to be cannulated much earlier, sometimes within days, avoiding the need for a bridging catheter in these challenging situations.
And finally, to complete the hierarchy, when are permanent tunneled cuffed catheters considered the primary long-term option?
Tunneled cuffed central venous catheters, TCCVCs, as a long-standing hemodialysis modality, should be considered when the creation of any arteriovenous fistula or graft is truly impossible, or potentially in patients with a very limited life expectancy, where the risks and time required for AVF-AVG creation and maturation might outweigh the benefits. That's recommendation 7, a class 2A, level C recommendation. Again, reinforcing that they are generally a less preferred option reserved for specific, well-defined circumstances due to their higher risks of infection and central vein stenosis.
Okay, that clearly outlines the decision-making process. Once the access is actually created, you mentioned the importance of immediate postoperative assessment.
Absolutely critical. Right there in the recovery room or soon after, you need to check for function. The key is palpating for a thrill or auscultating for a bruit over the anastomosis. If, after creation of a vascular access, there is no thrill or a bruit detected, further investigation should be considered immediately. That's recommendation 25, a Class 2A, Level C recommendation.
Why the urgency? What does the absence of a thrill or bruit mean?
It strongly suggests an immediate technical failure or early thrombosis. Something is wrong with the inflow or outflow, and it needs urgent diagnosis, often with duplex ultrasound, and potential revision right away to salvage the access. You also need to assess for signs of ischemia by checking capillary return and pulses distal to the access.
Okay, so that covers the creation phase thoroughly. What about things that can go wrong in that immediate perioperative period, the first few hours or days after surgery?
Yes, several early complications can occur. Bleeding and hematoma are relatively common. Excessive bleeding might relate to technique or anticoagulation use. Usually managed with direct compression, but persistent bleeding or large expanding hematomas might require surgical revision or evacuation to prevent infection or skin necrosis.
Infection can happen early, too.
It can, although late infections are much more common. Perioperative infections occurring within the first 30 days have a relatively low incidence, around 0.8% reported, but they often result from intraoperative contamination. They present with the usual signs: redness, swelling, pain, maybe systemic signs like fever.
How are early infections managed, especially with grafts?
Early infections involving synthetic grafts are particularly serious because they often involve the entire graft. Total graft excision is usually required in these cases, especially if there are systemic signs, bleeding, pseudoaneurysm formation, or involvement of the anastomosis. Sometimes the feeding artery, like the brachial artery, might need to be ligated, which is usually well tolerated.
What about non-infected fluid collections?
Seroma collections of clear fluid can occasionally occur around AVGs, though they're rare with AVFs. Small ones might resolve with aspiration and compressive dressings, but large or symptomatic ones might need surgical exploration to rule out infection or pseudoaneurysm.
And the big word, early thrombosis. The access just clots off right away.
Yes, this is a major cause of early access failure. It's particularly common in fistulas created with poor inflow or small vessels, or in grafts with low flow, patient hypotension, a hypercoagulable state, or sometimes an undetected stenosis proximal or distal to the access.
How do you salvage an access that thromboses early?
Prompt intervention is key. Thrombectomy, removing the clot, and revision of any underlying problem like a stenosis should be performed as soon as possible. That's recommendation 31, a Class 1, Level C recommendation. The goal is to declot it quickly before the thrombus organizes and damages the vessel or graft.
Is thrombolysis using clot-busting drugs an option for early thrombosis?
Generally, no. Thrombolysis should not be used for early vascular access thrombosis occurring within 7 days of creation. That's recommendation 32, a Class 3, Level C recommendation.
Why not?
Because the risk of bleeding from the fresh anastomotic suture lines or through the porous graft material is too high before adequate tissue incorporation and healing have occurred. Surgical thrombectomy or mechanical thrombectomy after a few days for grafts, combined with revision, is preferred.
And early ischemia. We touched on ligation for severe cases.
Right. Vascular access-induced limb ischemia can unfortunately manifest very early after creation. As we said, for early, severe limb-threatening ischemia, or for any case of early ischemic monomelic neuropathy, IMN, where steel isn't the obvious cause, the access should be ligated urgently. That's recommendation 30, a Class 1, Level C recommendation. It's a difficult decision, but preserving nerve function or limb viability must take precedence over salvaging the access in those acute, severe situations.
Okay. After navigating those potential early pitfalls, what about general post-operative care and instructions for the patient?
Basic measures include keeping the patient and the access limb warm to promote vasodilation, although the guidelines note this is sensible advice lacking strong evidence. Patients need clear instructions: how to check their access function daily by palpating for the thrill or listening for the bruit. They need to know to report its disappearance urgently.
And warning signs.
Yes, warning signs of infection, redness, pain, discharge, or bleeding. They need instructions on how to apply pressure for bleeding and easy access to urgent medical help if needed. Also, advice on avoiding compression or injury to the access arm is crucial.
Before we move on from creation, the guidelines also briefly touch on the training of the surgeons performing these procedures. What's the takeaway there?
It's a really vital point, often overlooked. The guidelines emphasize the importance of surgeon training, and particularly experience in vascular access surgery. They cite evidence showing that surgeons who performed a higher volume of AVFs during their training subsequently created more AVFs and fewer AVGs in their independent practice.
So more training leads to more fistulas being created.
It seems so. And importantly, surgeons creating a higher number of AVFs, like AFIEL 25, during training had significantly lower AVF failure rates later on. While there's some conflicting evidence on whether supervised trainees' outcomes match specialists, the operating surgeon's experience does appear to be a significant determinant of AVF outcome.
What's the implication for clinical practice?
It highlights the importance of having robust training programs in vascular access surgery. And from a referring clinician's perspective, it might underscore the value, where possible, of collaborating with or referring patients to surgeons or centers with demonstrated experience and good outcomes in vascular access creation. It's part of the overall quality system.
Absolutely. Ensuring the foundation is built correctly by skilled hands is paramount.
Couldn't agree more.
All right, let's do a quick recap here. We've covered the essential groundwork for creating vascular access. Key takeaways include the absolute necessity of venous preservation in pre-dialysis patients, Rec 13 Class 3 against damaging key veins. For the creation itself, consider pre-op hydration, Rec 14 Class 2A, give prophylactic antibiotics for AVGs and complex AVFs, Rec 15 Class 1, and consider pre-op antiplatelets, Rec 16 Class 2A. A thorough pre-op physical exam is crucial, Rec 17 Class 1, and regional anesthesia might offer benefits, Rec 18 Class 2A. Avoid routine systemic heparin due to bleeding risk, Rec 26 Class 3.
And the choice of access follows a clear hierarchy. Start distally in the non-dominant arm, Rec 5 Class 2A if vessels are adequate, Rec 19 Class 2A 2 millimeters. Go contralateral if there's a CVC pacemaker, Rec 20 Class 1. Prefer native veins over grafts whenever possible, specifically basilic vein transposition over upper arm grafts, Rec 21 Class 2A, Level A, and femoral vein transposition over lower limb grafts, Rec 22 Class 2A. Use specific grafts like biological for infection, Rec 23 Class 2A, or self-sealing for early need, Rec 24 Class 1. Reserve lower limb access, Rec 6 Class 2A, and permanent catheters, Rec 7 Class 2A, for when other options fail. Immediately post-op, check for thrombroot, Rec 25 Class 2A. Manage early complications like thrombosis promptly with thrombectomy revision, Rec 31 Class 1, avoiding early thrombolysis, Rec 32 Class 3, and ligate urgently for limb-threatening ischemia, or IMN, Rec 30 Class 1. Finally, surgeon training and experience clearly matter for outcomes. That's a great summary of the creation phase. It sets the stage for the ongoing challenge, keeping that access functional long-term.
Exactly. So once the access is created, and hopefully healing well, the focus shifts to making sure it matures properly and then maintaining it. This brings us to surveillance and monitoring. This seems like an area with a lot of ongoing discussion and perhaps some controversy.
It definitely is. Vascular access complications are a huge burden, a major cause of hospitalization, maybe 15–20% of admissions for dialysis patients. The basic concept behind surveillance has always been that stenosis narrowings develop over time in fistulas and grafts. Detecting and correcting these before they cause major problems like thrombosis or inadequate dialysis seems logical.
Right, the idea of preemptive intervention, find it early, fix it early.
Precisely. However, a critical takeaway from these 2018 guidelines is that whether routine prospective monitoring and surveillance using specific tests actually prolongs vascular access survival compared to simply relying on good clinical monitoring and intervening when problems arise, well, that is currently unproven.
Unproven. That challenges a lot of established practice, doesn't it? Many units have surveillance protocols with regular flow measurements or other tests.
It does. It reflects the findings of large randomized controlled trials and meta-analyses published before 2017, which largely failed to show a significant benefit for routine surveillance programs in terms of improving primary or secondary patency or reducing thrombosis rates over a strategy of careful clinical monitoring and reacting to clinical signs or symptoms of dysfunction.
So if routine screening tests aren't definitively proven to improve outcomes, what should clinicians be focusing on for ongoing access care?
The guidelines strongly emphasize two key things. First, the importance of the multidisciplinary team approach. Having a dedicated team at each hemodialysis center, ideally coordinated by a vascular access nurse coordinator, plays a proactive role in ensuring adequate dialysis dose delivery by maintaining access function and patency. This team approach is shown to reduce rehospitalizations, complications like thrombosis, extend the life of the access, and reduce the rate of CVC use.
So teamwork and coordination are key. What's the second thing?
The second, and perhaps most fundamental tool, is physical examination of the vascular access. This should be performed before every single hemodialysis session to monitor for dysfunction. That's recommendation 43, a Class 1 recommendation, level C. It's considered essential daily practice.
Class 1, Level C again, strongly recommended based on consensus. And they also recommend it for surveillance more broadly.
Yes. Routine physical examination is recommended for vascular access surveillance and monitoring overall. That's recommendation 44, also Class 1, but with level B evidence this time. So there's moderate evidence supporting its effectiveness as a surveillance tool.
What exactly does that routine physical exam involve?
It's the classic triad. Inspection looking carefully at the access arm for swelling, redness, skin changes, ischemic fingers, aneurysms, pseudoaneurysms, hematomas, prominent collateral veins, any signs suggesting stenosis. Palpation, feeling the pulse character upstream, assessing the thrill, its quality, intensity, location changes are key, feeling for aneurysms or pseudoaneurysms, checking for tenderness or induration. And auscultation, listening to the bruit with a stethoscope, assessing its pitch, high pitch often means stenosis, its duration, and listening along the course of the access, comparing proximal and distal sounds.
And the key is not just a single snapshot.
Absolutely not. The key is combining these findings, comparing them to the patient's baseline, and crucially, looking for changes over time. Documenting these findings and investigating any abnormal or changing signs with imaging, like duplex ultrasound, is critical for detecting problems early. The accuracy of physical exam does depend on staff training and experience, and the guidelines actually lament a noted decline in formal physical exam skills, urging a reversal of that trend.
So, the daily clinical check by trained staff looking for changes is the cornerstone, supported by moderate evidence. What about using those special surveillance tests then, like measuring access flow, QA, during dialysis? Where do they fit in if routine screening isn't proven?
They still have a role, but not as standalone screening tools that automatically trigger intervention based solely on a number. Access flow can be measured indirectly using techniques like the ultrasound dilution technique, UDT, or sometimes directly with duplex ultrasound during dialysis.
But the guidelines say not to rely just on the numbers.
Correct. While these measurements can detect stenosis, for example, low flow is associated with significant stenosis. The guidelines explicitly state that using surveillance with specific flow or pressure measurements as the sole basis for intervention is not appropriate.
Why the caution? If the flow is low, doesn't that mean there's a problem?
It often does, but the large trials didn't show that routinely intervening based only on those numbers improved overall outcomes compared to intervening based on clinical signs. So the guidelines recommend a more integrated approach. For instance, recommendation 46 states, when arteriovenous fistula blood flow measurements during dialysis indicate the presence of a vascular access stenosis based on a QA less than 500 milliliter, angiographic assessment of the access should be considered. That's Class 2A, Level B.
So the flow 500 millilumen is a trigger to consider further investigation, but presumably in the context of the clinical picture.
Exactly. It's not an automatic referral for intervention. The flow measurement needs to be correlated with physical exam findings or other clinical indicators of dysfunction, like difficulty needling, prolonged bleeding, inadequate dialysis. A significant decrease in flow over time is probably more important than a single absolute value. Similarly, specific thresholds for venous pressure measurements, like venous pressure adjusted for mean arterial pressure, VPMAP, are considered unreliable indicators of stenosis when used in isolation. Recommendation 47, likely Class 3, Level B, advises against intervention based solely on these pressure findings.
This really is a significant shift for units that rely heavily on routine QA or pressure monitoring triggers. The message is, the number alone isn't enough. It needs clinical correlation.
That's the core message regarding surveillance testing. Clinical assessment remains primary. Other factors monitored during dialysis, like recirculation rates or unexplained drops in KTV or URR, measures of dialysis adequacy, can also be clues pointing towards access dysfunction, particularly venous outflow stenosis. But again, they are often less sensitive or specific than flow measurements and need clinical correlation. The key is diagnosing inefficient dialysis when accompanied by signs of stenosis, as correcting the stenosis can then improve dialysis delivery.
What about using imaging like ultrasound for surveillance outside of the dialysis session?
Duplex ultrasound remains a very valuable tool. It can assess anatomy, measure diameters, detect stenosis, evaluate maturation, and identify complications like pseudoaneurysms or thrombus. It enhances the understanding gained from physical exam. However, routine DOS screening without clinical indication hasn't been proven beneficial either. It's typically used to investigate findings from the clinical monitoring or physical exam.
And the other imaging modalities for surveillance?
The same principles apply as for investigating dysfunction. Digital subtraction angiography, DSA, is the gold standard for visualizing the lumen, but should only be performed when subsequent intervention is anticipated, Rec. 12, Class 1, Level C. Avoid purely diagnostic DSA. Computed tomographic angiography, CTA, may be considered in specific cases, particularly for evaluating central venous stenosis if DUS or DSA results are inconclusive, Rec. 10, Class 2B, Level C. And critically, gadolinium-enhanced MRA is not recommended in ESRD patients due to the risk of nephrogenic systemic fibrosis, Rec. 11, Class 3, Level C. Non-contrast MRA is evolving, but not yet standard practice.
So the bottom line on surveillance seems to be prioritize consistent, high-quality clinical monitoring, physical exam, by trained staff. Use hemodynamic measurements and imaging judiciously to investigate clinical concerns, not as standalone screening tools triggering automatic intervention. And foster that multidisciplinary team approach.
That captures it perfectly. It's a more nuanced, clinically driven approach than perhaps was common practice before these guidelines.
Okay, this brings us logically to the act that happens at every single dialysis session, cannulation. This seems like another area where technique really matters for the long-term health of the access.
It's absolutely paramount. Correct cannulation technique, or lack thereof, directly influences the lifespan of the access, especially for autogenous fistulas. And the hemodialysis nurses performing this task play an absolutely vital role. Their skill and diligence are critical.
What are the key recommendations around cannulation, starting with preparing the skin?
Meticulous skin preparation should be performed prior to every cannulation attempt. That's recommendation 40, a Class 1, Level C recommendation. It's non-negotiable. Hemodialysis patients often have higher rates of bacterial carriage, like Staph aureus, on their skin, and infection is a major risk, particularly devastating for grafts.
And facilities should have a standard procedure for this.
Yes. Facilities performing hemodialysis should implement a policy for the performance of skin preparation for vascular access cannulation. That's recommendation 41, also Class 1, Level C. This ensures consistency and adherence to best practice, using approved antimicrobial solutions with appropriate contact times and staff wearing clean gloves.
What about managing the pain associated with needle insertion?
Pain is definitely a concern for many patients. The guidelines say that topical or intradermal anesthesia may be considered prior to cannulation in selected patients. That's recommendation 42, a Class 2B, Level C recommendation. Options include topical creams like lidocaine-prilocaine mixes, intradermal lidocaine injections, or coolant sprays.
And selecting the right needle size.
This is important for achieving the prescribed blood flow without damaging the access. Selection of needle size should be appropriate for the prescribed blood flow rate. That's recommendation 45, a Class 1, Level B recommendation. You need to match the needle gauge, larger gauge number to a smaller needle, to the desired blood pump speed, the estimated access flow, and the size of the vessel being cannulated. Generally, you start with smaller needles, like 17G for new fistulas, and increase the size to 16G, 15G, as the access matures and higher flows are needed, provided the vessel can accommodate it without issues like high negative arterial pressure or high positive venous pressure.
Okay, skin prep, pain management, needle size. Now, the different techniques for actually placing the needles. The guidelines describe three main ones.
That's right. They discuss the rope ladder technique, the area technique, and the buttonhole technique.
Can you briefly describe each?
Sure. The rope ladder technique involves using the entire length of the cannulation segment of the fistula or graft. Crucially, you use completely new puncture sites for each dialysis session, rotating systematically up and down the access, keeping sites a reasonable distance apart, for example, 3 centimeters from the anastomosis, maybe 5 centimeters between sites, and avoiding previously used spots until they're fully healed.
What's the advantage of that?
It distributes the needle sticks over the largest possible area. This spreads the wear and tear, potentially reducing the risk of aneurysm or pseudoaneurysm formation compared to concentrating punctures in one area. The disadvantage is that it requires a reasonably long segment of usable access.
Okay. What about the area technique?
The area technique, sometimes called cluster needling, involves using a more limited segment of the access, but rotating the puncture sites within that specific area for each session.
When would you use that?
It's useful when only a short segment of the fistula or graft is suitable for cannulation. The advantage is it allows access use, even with limited real estate. The major disadvantage is that repeated trauma, concentrated in a small area, significantly increases the risk of complications like aneurysms, pseudoaneurysms, thinning of the skin, and potential rupture.
Right. And the third one, the buttonhole technique. This one generates a lot of discussion.
It certainly does. The buttonhole technique, also known as constant site cannulation, is primarily used for AVFs, not AVGs. It involves cannulating the exact same site, using the exact same angle and depth every single time. Initially, this is done with sharp needles for maybe 6 to 10 sessions to deliberately create a well-defined subcutaneous tunnel track.
And then you switch needles.
Yes. Once that track is established, you switch to using special blunt dialysis needles for all subsequent cannulations. The idea is that the blunt needle follows the established track without cutting new tissue, minimizing trauma and pain. Ideally, a single experienced nurse should establish the track initially.
What are the proposed advantages of buttonhole?
Advocates suggest it can be easier for patients performing self-cannulation, potentially extends the life expectancy of the AVF by reducing trauma once the track is formed, leads to fewer hematomas, and might reduce aneurysm formation compared to area needling.
But there's a major downside, isn't there? The infection risk.
Absolutely. This is the Achilles heel of the buttonhole technique and the main reason for controversy. Multiple studies have shown a significantly increased risk of local access site infections and, more worryingly, bloodstream infections, bacteremia and sepsis, associated with buttonhole cannulation compared to the rope ladder technique.
Why is the infection risk higher?
It's often linked to difficulties in adequately sterilizing the constant puncture site and the potential for bacteria to colonize the tunnel track. Inadequate aseptic technique by staff or patients during scab removal and site preparation seems to be a major factor. While re-education on meticulous cleaning and scab removal has been shown to reduce infection rates in some studies, the inherent risk associated with repeatedly accessing the same spot remains a significant concern.
So the guidelines don't outright recommend or condemn buttonhole.
They describe it and acknowledge the potential benefits, but strongly highlight the increased infection risk as a major drawback that needs careful consideration and impeccable technique if it's used at all. It might be considered in specific situations, like a patient with a very short cannulation segment where rope ladder isn't feasible, but the infection risk is paramount.
It really sounds like, regardless of the specific technique used, the skill and experience of the nursing staff doing the cannulation are absolutely crucial.
That cannot be overstated. The guidelines cite DOPPS data powerfully illustrating this. Every 20% increase in the proportion of experienced staff nurses, defined as 3 years of HD experience, on a unit was associated with an 11% reduction in AVF failure and an 8% reduction in AVG failure.
Wow, that's a direct link between experience and outcomes.
It really is. Inexperience can lead to complications like infiltrations, hematomas, and damage to the access, regardless of the theoretical technique being used. High awareness, excellent skills, diligent monitoring, continuous evaluation, and ongoing education for nursing staff are absolutely essential for preserving access longevity.
What about care after the needles are removed?
Needle removal technique is also important. Needles should be removed at approximately the same angle they were inserted. Gentle, direct pressure should be applied over the puncture site after the needle is fully removed using a sterile dressing, just enough pressure to achieve hemostasis without occluding flow in the access. Holding pressure for too long or too hard can risk thrombosis. Checking for the thrill or brute after hemostasis is achieved and before the patient leaves is also a key safety check. Difficulty achieving hemostasis can sometimes be an early sign of downstream venous outflow stenosis.
Okay, so meticulous technique from start to finish. This really underscores the vital role of the nursing team, which leads us nicely into the specific section on nursing organization.
Yes. The guidelines explicitly recognize that nurses are pivotal in the day-to-day management of vascular access. They see the patients most frequently, perform the cannulation, assess function, educate the patient. Their role is central to successful outcomes, patient quality of life, and the overall efficiency of the service.
And they highlight the evolution of a specialized nursing role, the vascular access nurse or coordinator.
They do. This role has developed significantly. A dedicated vascular access nurse or coordinator can take on numerous responsibilities beyond basic cannulation. This includes developing and implementing protocols for access care, running monitoring programs, collecting and auditing data on access outcomes like patency rates, infection rates, CDC use, monitoring adverse events, ensuring quality control, and potentially even inserting central lines with appropriate training. The specific scope can vary between units.
And having this dedicated, coordinated role actually improves things.
The evidence suggests it does. A proactive, multidisciplinary team approach that includes a dedicated vascular access nurse coordinator has been shown to reduce rehospitalization rates, decrease complications like thrombosis, extend the overall functional life of vascular accesses, and lower the rates of CVC dependency.
That seems like a really strong argument for investing in these specialized nursing roles.
It is. The Vascular Access Nurse Coordinator acts as a central hub facilitating early patient referral for access creation, providing consistent education to patients and staff across different settings, liaising effectively between the dialysis unit, surgeons, and interventional radiologists, organizing the first cannulation, leading quality improvement initiatives, and defining standardized protocols for things like CVC care or AVF cannulation. It requires a highly skilled and educated nurse, often full-time in larger units, who can also support and mentor other nursing staff.
So what's the formal recommendation on this?
The appointment of one or more vascular access nurses should be considered to improve patient care and clinical outcomes in each hemodialysis service. That's Recommendation 51, a Class 2A, Level C recommendation.
Class 2A, Level C. So, strongly suggested based on expert opinion and observational evidence showing likely benefit, it really highlights that successful vascular access programs depend heavily on dedicated, expert nursing leadership and coordination.
Absolutely. It's not just about the surgery. It's about the entire system of care, and nurses are at the heart of that system.
Okay, let's pause for another recap. We've covered the complex and somewhat controversial landscape of surveillance, the key takeaway being that routine testing alone isn't proving superior to excellent clinical monitoring. Physical exam is paramount, Rec. 43-44. Hemodynamic measures need clinical correlation, Rec. 46-47. We've discussed cannulation, meticulous skin prep, Rec. 40-41. Appropriate needles, Rec. 45, the pros and cons of different techniques, especially the infection risk with buttonhole, and the critical role of nurse experience. And finally, the guidelines strongly advocate for considering dedicated vascular access nurse roles to coordinate care and improve outcomes, Rec. 51.
A great summary. It emphasizes the shift towards clinically driven surveillance and the importance of the human factors skilled assessment and expert nursing care in maintaining access function.
Right. So we've covered creation and the principles of ongoing maintenance and surveillance. Now, inevitably, things can still go wrong later in the life of the access. Let's dive into the management of specific late vascular access complications.
Yes. Unfortunately, these are common occurrences and often require timely intervention to either preserve the access or deal with significant patient morbidity issues.
Let's start with aneurysms and pseudoaneurysms. What's the difference again, and how do they arise?
Okay, so some generalized enlargement or dilation of a native AVF is normal. That's flow-induced remodeling. A true aneurysm is a localized balloon-like dilation that involves all layers of the vessel wall. These often occur in AVFs and can sometimes be caused or exacerbated by an underlying stenosis downstream, which increases pressure in the segment before it. A false aneurysm, or pseudoaneurysm, isn't a true dilation of the vessel wall. It's essentially a contained rupture or leak from the vessel, where blood collects outside the vessel but is contained by surrounding tissue, forming a pulsating sac. These are much more common in AVGs and are usually caused by repeated needle trauma damaging the graft material, or sometimes occur at the graft vessel anastomosis.
How common are these, and how do we detect them?
They're fairly common. True aneurysms might occur in up to 15–17% of AVFs over time. Pseudoaneurysms may be around 7% in AVGs. They're usually easily detected clinically. You can see or feel the pulsating bulge. Duplex ultrasound is very helpful to confirm the diagnosis, assess the size, check for thrombus within the aneurysm, and crucially, look for any associated stenosis that might be driving the problem.
When do these need intervention? Does size alone dictate treatment?
Not necessarily size alone, although rapid expansion is a concern. The main indications for urgent evaluation and treatment are related to the risk of rupture or skin breakdown. Specifically, aneurysms or pseudoaneurysms that have very thin, shiny, or eroded overlying skin, or those that have shown signs of minor bleeding or ulceration need urgent attention. Also, AVG pseudoaneurysms that significantly limit the available space for cannulation cause pain, are associated with poor scar formation, or are rapidly expanding should be surgically revised. That's Recommendation 53, a Class 1 Level C recommendation.
And for true aneurysms in AVFs?
For true AVF aneurysms, surgical revision, like aneurysmectomy or bypass, is recommended if the revision can preserve adequate cannulation sites and maintain the overall function and diameter of the access. That's Recommendation 52, also Class 1, Level C. The goal is to fix the problem while saving the access if possible.
Is endovascular treatment an option, like using stent grafts?
It can be. Stent graft exclusion of vascular access aneurysms or pseudoaneurysms may be considered in selected patients. That's recommendation 54, a class 2B level C recommendation. It's an alternative, perhaps less invasive for some patients, but the long-term durability compared to surgery isn't fully established.
And a critical point about cannulation.
Yes, absolutely critical. Access cannulation directly through a pseudoaneurysm is not recommended and should be avoided. That's recommendation 55, a class 3 level C recommendation due to the extremely high risk of rupture. You need to cannulate away from the pseudoaneurysm. Also, importantly, in any symptomatic aneurysm or pseudoaneurysm, an underlying outflow stenosis should be ruled out and treated if present, as it's often the root cause. That's recommendation 56, class 1, level C.
Okay, moving from structural problems to infection. This is a major source of morbidity and mortality risk.
Huge. It's a leading type of infection in hemodialysis patients overall, and the second most frequent cause of death after cardiovascular disease. Dialysis patients are inherently at higher risk due to uremia affecting immunity, often having diabetes or other comorbidities, and of course the repeated vascular access interventions like cannulation.
Where does infection most commonly occur? Access type matters.
Very much so. The risk is by far the highest with central venous catheters. Among permanent accesses, AVGs have a significantly higher infection risk than AVFs. Native fistula infections are relatively rare but can occur. Diagnosis is usually clinical local signs of redness, swelling, pain, discharge, but sometimes infections can be occult, presenting only with fever or systemic symptoms. DUS might show paragraph fluid collections, and sometimes radio-labeled white cell scans are needed. Even non-used thrombosed accesses can pose an infection risk.
What are the usual culprits, the organisms involved?
Predominantly gram-positive cocci, with Staphylococcus aureus being the most common by far, accounting for 50–90% of cases in many series. Staphylococcus epidermidis is also common, along with various Streptococcus species. Gram-negative organisms account for maybe a third of infections.
How are these late infections managed, starting with antibiotics?
Yes. All late vascular access infections should be treated initially with empirical antibiotics that cover both gram-positive and likely gram-negative organisms, pending culture results. That's recommendation 57, class 1, level C. Once sensitivities are known, the therapy can be narrowed. For primary AVF infections, a long course, maybe 6 weeks, is often suggested, analogous to endocarditis treatment, although the guidelines admit strong evidence for duration is lacking.
And what about infected grafts? This sounds much more serious.
It is potentially life-threatening due to the risk of sepsis and catastrophic bleeding from disruption of the graft vessel anastomosis. For late infections involving AVGs, particularly if there are signs of sepsis, clear clinical signs of widespread graft infection, or imaging showing fluid around the whole graft, then total arteriovenous graft excision is recommended. That's recommendation 58, a class 1 level C recommendation. You often have to remove the entire infected foreign body.
Is partial excision ever an option for infected grafts?
It may be considered in very selected cases. That's recommendation 59, a class 2B level C recommendation. This might be attempted if the infection appears clearly localized to one section of the graft and other parts seem well incorporated and uninfected. The potential advantage is avoiding the need for a temporary CVC while waiting for a new access. However, the risk of recurrent infection is higher than with total excision, which generally offers the best chance of cure.
Okay, that's clear. Let's move on to stenosis, the narrowing of the access pathway. This is probably the most common underlying problem leading to dysfunction and thrombosis.
Absolutely. Stenosis is the bread and butter of access maintenance problems. It can occur anywhere along the circuit, from the arterial inflow feeding the access, right at the anastomosis, within the fistula vein or the graft itself, or along the venous outflow pathway, including the central veins.
But remember, we don't necessarily treat all stenosis we find on imaging.
Correct. The principle established earlier holds. Preemptive treatment of all angiographically identified stenosis has not been shown to be beneficial. Intervention is generally reserved for stenosis that are considered hemodynamically significant, usually defined as a 50% or sometimes a 70% diameter reduction, and are associated with clinical signs of dysfunction, like decreased flow on measurement, elevated venous pressures during dialysis, difficulty cannulating, prolonged bleeding post-dialysis, or abnormal findings on physical exam, like a changing thrill or bruit.
So, treat the problematic ones. How do we manage stenosis depending on where it occurs? Let's start with inflow stenosis, in the artery feeding the access or right at the arterial anastomosis.
Inflow stenosis accounts for a significant proportion of dysfunctional accesses. The primary treatment is usually endovascular percutaneous transluminal angioplasty, PTA, using a balloon to stretch the narrowed segment open. PTA for inflow stenosis is generally safe and effective with reasonable patency rates.
What if PTA alone doesn't work well or the stenosis comes back quickly?
If there's significant elastic recoil immediately after PTA, if the stenosis recurs rapidly, or if there's a residual narrowing of more than 30% after ballooning, then stent implantation is recommended to scaffold the vessel open. Open surgical options like bypass or endarterectomy are less commonly performed for inflow stenosis these days, and there aren't good randomized trials comparing them directly to endovascular treatment.
What about stenosis occurring right near the anastomosis or in the first few centimeters of the fistula vein or graft, the juxta-anastomotic region?
This is another very common site for stenosis, especially in AVFs. Traditionally, surgery, like creating a new, more proximal anastomosis or placing a short interposition graft, was often preferred, particularly for forearm AVFs, as PTA results were thought to be less durable here. However, PTA is certainly an alternative and can be used as the primary approach.
But with a higher chance of needing reintervention.
Yes, PTA in this juxta-anastomotic zone often has a higher rate of recurrent stenosis compared to surgical revision. So if PTA fails early or recurs quickly, surgical revision is usually indicated. But if surgery would significantly shorten the usable length of the AVF, then attempting PTA first, even knowing it might need repeating, is often justified.
Moving further downstream, venous outflow stenosis in the peripheral veins of the arm.
This is suggested by signs like reduced access flow, prolonged bleeding after needle removal, or elevated venous pressures during dialysis. It often occurs where a superficial vein like the cephalic or basilic dives deeper to join the main axillary or brachial veins. Again, PTA is generally the first-line option for treating stenosis in these outflow veins, especially for shorter lesions, less than 2 centimeters.
What about longer segments of venous stenosis?
Treatment for long-segment venous outflow stenosis, 2 centimeters, is more controversial. Both PTA, sometimes requiring multiple balloons or prolonged inflation, and open surgery, like creating a bypass graft around the stenosis or vein interposition, are options, and the best approach might depend on the specific anatomy and local expertise.
Now, the really challenging one. Stenosis in the large central veins, the subclavian, brachiocephalic, or superior vena cava, central venous obstruction disease, CVOD.
Yes, CVOD is a significant and growing problem, especially in patients with a history of previous central venous catheters, particularly subclavian lines. It can cause arm swelling, pain, high access pressures, and ultimately access failure.
How is symptomatic CVOD managed?
Diagnosis is usually suspected clinically and confirmed with fistulography or sometimes CTA, as DUS is often limited in visualizing these deep central veins. For symptomatic stenosis causing problems, balloon angioplasty, PTA, is recommended as the first-line treatment. That's recommendation 68, a class 1 recommendation, level B. PTA can often improve symptoms and allow continued use of the access.
But how durable is PTA for central veins?
Unfortunately, patency rates after PTA alone for central venous stenosis are often poor, with high rates of recurrence, especially for lesions that have recurred previously.
So what's the next step if PTA fails or isn't enough? Stenting.
Yes. Stenting should be considered for central venous stenosis that is refractory to balloon angioplasty, meaning it recoils immediately or doesn't dilate well, or that recurs quickly. That's recommendation 69, a class 2A, level C recommendation. Studies show that stenting generally provides better immediate results and longer-term patency than PTA alone for symptomatic CVOD.
Are there downsides to placing stents in central veins?
Yes. The main concern is that placing a stent, especially a long one, can potentially compromise future access options on that side, or even the other side, if it extends across the midline. However, it's often necessary to preserve the current access and relieve debilitating symptoms like severe arm swelling. Newer approaches like stent grafts, covered stents, are showing promise, particularly for recurrent lesions or occlusions, and drug-eluting balloons are also being investigated as a potential alternative to bare metal stents in some situations.
What about specific locations? Is stenosis near the thoracic inlet treated differently?
Yes. Stenosis occurring right where the subclavian vein passes between the clavicle and the first rib, the thoracic inlet, often represents venous thoracic outlet syndrome or compression. These lesions respond very poorly to PTA, and stents placed here almost invariably fracture or fail due to the external compression. The treatment of choice for symptomatic thoracic inlet stenosis is surgical decompression, usually involving resection of the first rib and freeing up the vein, venolysis. Any residual stenosis might then be treated with PTA after the decompression. Stenting should generally be avoided here.
And if a central vein is completely occluded, not just stenosed?
Complete central venous occlusions are extremely challenging. Endovascular recanalization, drilling through the blockage, is sometimes possible but difficult and carries risks. Open surgical reconstruction with long bypass grafts, for example, from the axillary vein to the contralateral jugular vein or even down to the femoral vein or IVC, are complex, major tertiary procedures with high failure rates, reserved for desperate situations. We'll touch more on those complex options later. But first, let's make sure we check for CVO when indicated. After access creation, persistent arm edema should be evaluated by fistulography or CTA to assess central venous patency. Rec 66, Class 2A, Level C.
Okay, that covers the spectrum of stenosis. Now, thrombosis, the access clotting off completely. This is often the end result of an untreated stenosis, right?
Exactly. Thrombosis is usually the final complication after a period of progressive stenosis causes flow to slow down critically. Sometimes it can be triggered by hypotension, like during dialysis or illness, or external compression. Treating thrombosis promptly is crucial to salvage the access, prevent the clot from organizing and damaging the vessel wall or graft, and avoid the need for a temporary CVC.
How urgently does it need to be treated? Does it differ between fistulas and grafts?
AVF thrombosis is generally considered more urgent than AVG thrombosis. This is because the organized thrombus can cause more significant damage to the native vein endothelium, making successful salvage harder if delayed. Prompt thrombectomy, within 24 or 48 hours if possible, is ideal for AVFs. Historically, this was done surgically. Later, endovascular techniques using clot-dissolving drugs or mechanical devices were developed. Evidence comparing surgical versus endovascular thrombectomy outcomes for AVFs is conflicting. Some studies suggest surgery might offer better long-term patency.
But removing the clot isn't enough, right? You have to fix the underlying problem.
Absolutely. Thrombolysis or thrombectomy alone is insufficient because there's almost always an underlying stenosis, often 85% narrowing, that caused the clot in the first place. Identifying and successfully treating that underlying lesion, usually with PTA plus stenting, during the same procedure is crucial for achieving any reasonable long-term patency after declotting. Combined thrombolysis thrombectomy plus PTA can achieve good immediate technical success, up to 90%. But the subsequent 6-12-month patency rates vary widely, maybe 35–60%.
What about AVG thrombosis? Less urgent.
Slightly less urgent in terms of vessel damage, perhaps, but still needs to be managed promptly, ideally without the patient missing their next dialysis session. Early declotting allows immediate use. Older thrombi, more than a few days, become more organized and harder to remove, especially surgically. Endovascular techniques are very successful for AVG thrombosis. The preferred method is often a combination of mechanical thrombectomy, breaking up the clot, and/or pharmacological thrombolysis, followed immediately by angiography to identify and treat all underlying stenosis with PTA or stenting. Again, successful treatment of the underlying stenosis is the only factor consistently shown to predict subsequent graft patency.
Okay, that covers stenosis and thrombosis. What about vascular access-induced limb ischemia, VALI, the access stealing blood flow from the hand?
Yes, this is another significant potential complication, causing pain, coldness, numbness, or even tissue loss in the hand or fingers distal to the access. It occurs in roughly 1 to 8% of AVFs and maybe 3–12% of AVGs.
Are certain patients or access types more at risk?
Yes, the risk is higher in patients with diabetes, older age, female sex, underlying peripheral artery disease, PAD, and when the brachial artery is used as the inflow vessel for the access, as in upper arm AVFs or AVGs, compared to the radial artery, wrist AVFs. Grafts also tend to have a higher incidence than fistulas.
How is VALI classified and managed?
It's often classified into stages based on severity, from mild symptoms only on exertion or during dialysis, to rest pain up to tissue loss, ulcers, or gangrene. A particularly severe form is ischemic monomelic neuropathy, IMN, which is primarily nerve ischemia causing severe pain and sensory-motor dysfunction, often without the classic signs of poor tissue perfusion.
How do you approach treatment?
Mild ischemia might improve over time as collateral circulation develops. Careful evaluation is needed to rule out other causes like carpal tunnel syndrome or venous hypertension causing swelling. Regular monitoring and careful evaluation are crucial, especially in high-risk patients. Clinical exam includes checking pulses, listening for bruits that might indicate a proximal arterial stenosis feeding the access, checking bilateral blood pressures, and potentially measuring digital pressures or ankle brachial indices, ABI.
What if the ischemia is severe?
For severe ischemia characterized by non-healing ulcers, digital necrosis, or to threaten limb access ligation, tying it off, may unfortunately be the only option to restore adequate perfusion to the hand.
And for milder but still problematic, ischemia like pain during dialysis or rest pain.
The goal here is to diagnose the underlying cause and treat it in a way that reduces the distal ischemia while preserving the function of the vascular access if possible.
What are the potential causes and treatments?
If there's an arterial inflow stenosis proximal to the access anastomosis that's limiting overall flow to the limb, then treating that stenosis with PTA should be considered. That's recommendation 70, class 2A, level C. Fixing the inflow can sometimes improve both access flow and distal perfusion. More commonly, the problem is high flow through the access itself, causing excessive steal from the distal circulation. In these cases, flow reduction procedures should be considered. That's recommendation 73, class 2A, level C.
What kind of procedures reduce flow?
Options include banding, surgically placing a narrowing band around the fistula vein or graft to increase resistance, surgical revision to narrow the anastomosis, revision using distal inflow or UDI procedure, or sometimes ligating one limb of a loop fistula. The goal is to reduce the access flow just enough to alleviate the steal symptoms without causing the access to thrombose. Intraoperative flow monitoring during these procedures is often advised. Very high access flow, 1,500 to 2,000 millimin, can also sometimes contribute to high output congestive heart failure, CHF. Patients with such high flow should be monitored regularly with flow measurements, echocardiograms, clinical assessment, and if CHF develops or worsens, flow reduction procedures might also be considered for that indication.
And neuropathy. You mentioned ischemic monomelic neuropathy, IMN.
Yes. IMN is a distinct and devastating complication, usually occurring early after access creation using the brachial artery. It's thought to be due to acute ischemia, specifically affecting the peripheral nerves of the forearm and hand. Patients experience severe pain, weakness, and sensory loss, often disproportionate to any visible signs of tissue ischemia. The hand might still be warm with palpable pulses. It can mimic severe steal, post-op edema, or even carpal tunnel syndrome, but the neurological deficit is key.
How is IMN treated?
Because it's primarily nerve ischemia and potentially irreversible if delayed, the recommendation is for immediate vascular access closure, ligation, to maximize the chance of nerve function recovery. That's recommendation 74, a class 1, level C recommendation. Unfortunately, even with prompt ligation, persistent neurological deficits are common. Other causes of neuropathy related to access surgery include direct nerve trauma during dissection, local anesthetic toxicity, or compression from hematoma or edema. Carpal tunnel syndrome can also be exacerbated or precipitated by the increased venous pressure or flow from an AVF.
Okay, that covers the major complications. Let's quickly recap those. For aneurysms, pseudoaneurysms intervene for skin changes, bleeding expansion, Rec 52, 53 class 1. Consider stent grafts, Rec 54 class 2B. Don't cannulate pseudos, Rec 55 class 3, and treat outflow stenosis, Rec 56 class 1. For infection, use broad antibiotics, Rec 57 class 1. Perform total graft excision for sepsis widespread signs, Rec 58 class 1. Maybe partial excision in select cases, Rec 59 class 2B.
For stenosis, treat hemodynamically significant lesions causing dysfunction. Use PTA plus stentus for inflow juxta-anastomotic peripheral outflow. For CVOs, PTA first, Rec 68 class 1. Consider stents if refractory, Rec 69 class 2A. Investigate persistent edema, Rec 66 class 2A. And use surgery for thoracic inlet. For thrombosis, treat ASAP, always addressing the underlying stenosis. For VALI, consider PTA for inflow stenosis, Rec 70 class 2A. Consider flow reduction for high flow steal, Rec 73 class 2A. And ligate urgently for severe ischemia or IMN, Rec 74 class 1.
Excellent summary. Now, one last scenario before complex access. What happens when a patient receives a successful kidney transplant and theoretically no longer needs their dialysis access? Should it be routinely closed?
This is a common question. The guidelines are quite clear. Routine closure of a functioning vascular access after successful kidney transplantation is not recommended. That's recommendation 75, a class 3, level C recommendation.
Class 3, so actively recommended against routine closure. Why?
Because most functioning AVFs or even AVGs remain patent after transplant without causing significant problems. Closing them involves another surgical procedure with its own risks. And crucially, preserving the access provides a potential lifeline should the kidney transplant unfortunately fail later on, avoiding the need to start all over again with access creation, possibly in a worse situation.
But are there situations where closure is indicated post-transplant?
Yes, definitely. Closure should be considered in specific high-risk patients or if the access is causing problems. The main indication highlighted is for patients with refractory heart failure after transplantation, where the high flow from the access might be contributing. That's recommendation 76, a Class 2A, Level C recommendation. Closure might also be considered if the access itself is problematic, for example, if it has a history of infection, is causing significant steal symptoms even post-transplant, has large unstable aneurysms, or poses a high thrombosis risk that requires ongoing intervention. Also, thrombosed grafts, even if non-used, can still pose an infectious risk and might warrant removal.
So no routine closure, but selective closure for specific indications like refractory CHF or problematic access itself.
Exactly. It's an individualized decision based on the patient's overall condition and the status of the access.
Okay, now finally, let's tackle the most challenging end of the spectrum. Patients needing complex or tertiary hemodialysis vascular access. Who falls into this category?
These are typically patients where standard upper limb options, both native fistulas and grafts, have been exhausted or are impossible. This often happens in patients with a long history on dialysis, multiple previous failed accesses leading to extensive venous scarring or thrombosis, particularly central venous occlusions, or perhaps patients with failed transplants who have become highly sensitized.
So very limited options left.
Very limited. Creating access in these patients often requires non-standard approaches, significant surgical inventiveness, and accepting higher risks. It's the end of the line for access creation in many ways.
How did the guidelines approach this? Is there a suggested classification or sequence?
They suggest a pragmatic classification based roughly on the location and complexity, implying a sequence of increasing risk. Group 1 includes procedures still utilizing upper limb or chest wall vessels, or perhaps using an autogenous vein translocated from the lower limb up to the arm. These are generally preferred if feasible because they avoid the higher risks associated with lower limb access.
What kind of procedures fall into Group 1, especially if central vein occlusion is the main problem?
If standard endovascular attempts like venoplasty or stenting of the central veins have failed, Group 1 surgical options might include creating bypasses. For example, using a prosthetic conduit to bypass the occluded segment, perhaps connecting the axillary vein remnant to the contralateral jugular vein, a necklace graft across the chest, or bypassing down from the arm vein to the femoral vein, or IVC, spanning the diaphragm. The idea is to find some patent outflow pathway back to the heart. Another Group 1 option mentioned again here is the HERO device, hemodialysis reliable outflow, which is specifically designed for patients with patent inflow arteries, but occluded central venous outflow, acting as a hybrid graft catheter system.
Okay, so Group 1 tries to stay north of the diaphragm or use native tissue if possible. What about Group 2?
Group 2 involves using the lower limb for access creation. As we discussed earlier, Rec 22, femoral vein transpositions are generally preferred over prosthetic grafts, bridging the femoral vessels in the groin or thigh, mainly due to the very high risk of infection associated with the prosthetic material in the groin area, reported rates of 18–37%. Obesity might be a relative indication for FET over a graft in this location.
And Group 3, the most complex.
Group 3 encompasses procedures that might span the diaphragm using prosthetic grafts or other highly unusual access configurations, often tailored to the patient's unique anatomy. This also includes prosthetic arterial loops.
Arterial loops, how do they work?
These connect an artery back to another artery, usually using a prosthetic graft loop placed subcutaneously, for example, between the axillary arteries across the chest wall or between the femoral arteries in the leg. The key difference is they don't involve the venous system, so they don't cause the same high flow state or increased cardiac demand as an AV fistula or graft. They might be considered in patients with no usable venous outflow to the heart or those at very high risk of steel ischemia or heart failure.
Are they safe? Effective?
They carry significant risks. Axillary loops have had high infection and mortality rates reported. Femoral arterial leg loops seem to have better patency in some series, but if they thrombose, it requires immediate thrombectomy for limb salvage, unlike AVG thrombosis, which doesn't usually cause acute limb threat. Other anecdotal Group 3 attempts mentioned include grafts to the renal vein or even directly to the right atrium via thoracotomy. These are truly last-ditch efforts with extremely high expected mortality.
So the overall recommendation for these complex situations?
When standard upper limb vascular access sites have been exhausted, complex access procedures should be considered according to the availability of suitable vessels and local expertise. That's recommendation 77, a Class 2A Level C recommendation. It acknowledges these are necessary options in dire circumstances.
What about complex central venous catheters as a tertiary option? Things like lines placed via the lumbar veins or through the liver into the IVC.
The guidelines mention these translumbar or transhepatic catheters or lines placed through native kidneys or failed allografts. These are truly salvage procedures associated with significant morbidity and mortality risks related to insertion and subsequent complications.
So when should they be considered?
Only as an absolute last resort. The recommendation is strong. Individuals should not undergo the insertion of a high-risk complex hemodialysis line without serious consideration of all other potential options first, including complex surgical access, groups 1 to 3, and importantly, peritoneal dialysis. That's recommendation 78, a class 3 level C recommendation. Basically, exhaust every other possibility before resorting to these extremely high-risk lines. PD should always be considered, as it can often be placed safely even after abdominal surgery.
That paints a stark picture of the tertiary access challenges. To wrap up this section, the guidelines are comprehensive, covering a vast range of scenarios, but they are also honest about where the evidence is still lacking, aren't they?
Absolutely. It's a crucial final point. They explicitly acknowledge that robust evidence is still needed for many aspects of vascular access care, which is why many recommendations are level B, or more often level C, expert opinion.
What are some of the key areas they identify as needing future research?
It's quite a list. They call for trials on long-term durability of different prosthetic grafts and CVCs. A trial comparing AV access versus CVCs specifically in the elderly was needed. One was launched around 2016. A registry to track outcomes of post-VA creation ischemic neuropathy would be valuable. More research is needed on patient-specific choices like, should someone with limited life expectancy get an AVG versus an AVF? How do different HD techniques, high-flow intensive HD, affect access? Should age alone dictate access modality? What's the real impact of cannulation hemodynamics and needling damage? What is the best treatment for central venous obstruction disease? How can we better organize early patient referral and pre-dialysis care, including implementing venous preservation policies? We need long-term follow-up and cost-benefit analyses for current treatments. Studies on tissue-engineered grafts, new anastomotic technologies like laser or endovascular AVF creation, the effect of VA creation on residual kidney function in CKD 4 to 5 patients, and fundamentally a better understanding of the pathophysiology of intimal hyperplasia, the process that causes stenosis.
Wow, that's a significant research agenda. It really highlights that while these guidelines provide a strong framework based on the knowledge up to 2017, our understanding is still very much evolving.
Precisely. It serves as a reminder for all of us that vascular access management is a dynamic field. Continuous learning, critical appraisal of new evidence as it emerges, and participation in research efforts are all essential to keep improving care for these patients.
And that brings our deep dive into the 2018 ESVS Clinical Practice Guidelines for Vascular Access to a close. We've journeyed through the rigorous methodology, the changing patient demographics, the intricacies of access creation, the ongoing challenges of surveillance and cannulation, and the complex management of both common and rare late complications, right through to tertiary access strategies and the acknowledged gaps in our knowledge.
It's been a comprehensive exploration. We hope that unpacking these guidelines in detail has provided you, the specialist clinicians listening, with clearer, actionable insights drawn directly from this key document. The goal is to help you better navigate the daily challenges of caring for your hemodialysis patients, armed with the best available evidence.
As you reflect on this wealth of information, perhaps consider this question. Given those persistent challenges we discussed, particularly with central venous obstruction and the limitations of our current stents and surgical bypasses, how might future innovations, maybe drawing from fields like regenerative medicine, advanced biomaterials, or even nanotech, fundamentally change how we approach and manage central venous outflow for our most complex patients in the decades to come?
And building on that strong evidence, highlighted for the crucial role of the multidisciplinary team and skilled, dedicated nursing care, what are the most impactful practical steps we, as a diverse clinical community across all the involved disciplines, can take today in our own units and systems to better implement these organizational recommendations and truly improve patient outcomes, even if resources are constrained? What small changes can make a big difference?
Plenty to think about. Thank you for joining us for this deep dive into the ESVS Vascular Access Guidelines.